Andre, Michael Bachrach here. Servus. So we're anxious to hear your case, and our panelists are just coming on the board.
Okay, very good. Yeah, say hello to everybody. Shall we start?
Yes. Yes, go ahead, please.
Okay, very good. Yeah, so fine, thank you. So we want to present here a case using the Rotarex, which we think is a very good thrombectomy device, also for more chronic disease. Usually we have here an instant reocclusion. However, we had 2 patients scheduled, several reasons why they couldn't come. Now we have another case, which is actually not an instant, but hopefully a good case to demonstrate the effect of the Rotarex device. So maybe, Matthias, you can introduce the case?
Yes, of course, yes. So it's a 72-year-old male patient. He has claudication, left calf walking capacity is 100 meter. There was a TEA performed in the left groin beginning of 4/19 this year, 2 to 3 months ago. And he has an arterial hypertension. Next slide shows you the angiogram, which we did immediately after the TEA because he had still some symptoms. We found that the groin was very well after the operation, but now we have some thrombus in the SFA. So before operation, we only had a very short distal SFA occlusion. Now we have a longer occlusion with a lot of thrombotic material in. Run off below the knee, we have 3 vessels. Next slide. So this is the strategy. We are in the right side, crossover approach to left. We have 8 French sheaths in. We already managed to bring the wire down. We can show you now. And then the plan is to do the Rotarex thrombectomy, and then we want to PTA and maybe also put stents in using a drug. Okay, if you switch to the next.
To the Let's switch to the angio. Yeah. Here once again the angio. So you can see groin okay now, but that portion of the SFA here over the whole screen was actually open before surgery. Now there's quite some thrombus in. This is now subacute, 2 months old thrombus, and here once again more distal and occlusion, which actually was initially 2 centimeter long, but now also longer distal to that. That's actually okay. Yeah, outflow is okay, which of course we need to check before we treat here some thrombotic lesion. Yeah, so a mix of thrombotic and chronic disease. We started already to take the wire through. This is here, again, our standard wire first, the command 18, which however here went more subintimal here around that distal area. We changed then to a CTO wire, connect 250T. This is usually our next step. As in the other case we showed already this day. So here first some problems here, was subintimal, but eventually after some more attempts, it very nicely went through. Yeah, so after that we pushed down here the quick cross, which is actually a support catheter tracking over an 0.35 inch wire, you can see here, and needed some force to bring it here through that disease. And that's actually where we are now. So the plan is in fact to really clean as much as we can, to thereafter balloon, of course, more distal, potentially stent. And I think, yeah, maybe this is a good strategy to do that. We first clean everything before we balloon the distal occlusion. I think by this we have some kind of natural filter here. Okay, shall I give you a roadmap or something?
Yeah, no. Or maybe just a little puff that I know where the...
Stop.
So the roadmap will not help very well.
Okay.
Just to know where the offspring of this is.
It's a little hard to inject now. Okay. As you know, we have a 6 French device, but also an 8 French device. We think 8 French is a very good device for SFA lesions. As in fact, also now at 10.5 till device now available. Yeah. So maybe maybe those who are not so familiar with this, it's a long spiral, like an Archimedes spiral, which rotates 40,000 rakes per minute. And by this creates a very strong aspiration force. And the head, which you can see here, is rotating, has some openings, 2 openings on the side. And by the rotation, fragmentates the thrombus, and by the aspiration, the thrombus is taken out. It's really very, very effective.
I can feel some resistance now here, distal.
Andre, in relationship to other rotational devices, do you have to worry about it heating? Do you have to stop every so often? Is there some technical aspects of how to use this atherectomy device?
Yeah, in fact, with the older device, but this really has been improved tremendously. There was quite sometimes some heating, especially in very steep aortic bifurcations. You can really feel it at your fingers that it would become very hot, and then you had to stop occasionally and take it down once again. With the newer devices, braided shaft here, this occurs actually relatively rare, much better. So you can see Matthias is going forth and down, forth to fragmentate and aspirate.
Yeah, and also I do it very frequent to avoid rotation at one point at the bifurcation.
Yeah.
Matthias, can you explain why you are pulling back the system very fast and advancing in a slower, not so fast as you are pulling
Two
back?
aspects. So two aspects. One aspect is that I can do fragmentation of the thrombus, and if I pull it back, I have some flesh with blood from above, which helps to suck and transport it out. But the other thing is, if you look at the bifurcation here, you see there is a little bit more stretch and more, let's say,
it's relatively steep, yeah.
relatively steep. And if you stay on one point and move, then it's getting hot at this area, and you can the products can broke there.
Also, using a Rotarex in in-stent, it's absolutely benign. There is no risk that you can perforate somehow. But working in a native artery, this, as I said, the aspiration forces are really very strong. If you get too close for a longer time to the arterial wall, you may easily pull the arterial wall into the device and rip a nice hole into the artery. So therefore also that if you feel resistance, if you take 8 French rather than 6 French, maybe these faster movements are better than slower ones.
But however, everyone is doing it a little bit different. I think that's not such a big difference if you go fast or slow. Sometimes at the bifurcation, you pull a little bit harder, okay?
Okay. Let's do an angio.
The next question, Andre. I am observing that you don't have a distal protection.
Yeah, so rare that we actually use distal protection for Rotarex, as we believe very much in the aspiration forces. And second reason here is that natural occlusion distal to the thrombus. So therefore, we thought that could be a natural filter here to prevent any embolization. Yeah, maybe there's still some thrombotic disease.
Maybe also intima. We are close to a perforation there, huh?
Yeah, well. Yeah, what do you think? I mean, it's always difficult to treat lesions which contain both thrombus and arteriosclerosis. With ballooning, you always have the risk that you embolize something.
Yeah. So for me, two options there: to go with balloon, to go with a filter down, or put a stent and go for post-dilatation. Maybe also an option.
Yeah. Yeah, what do you think? I'm not sure whether we can improve this with thrombolysis now overnight or so. I think looks to me more like now an organized thrombotic material here, which we partially could clean out. I think we have to continue now.
Yeah.
The question is how. I think ballooning, we will not come along without ballooning, and ballooning always has the risk here to embolize something. So,
Shall we move to rotor?
in fact, in this case, maybe since we still do have some material in here, we may use a filter. What do you think?
Yes.
Would you use a filter here? We can also do some more passes with Rotarex.
Let me ask the panel, would any of you have done primary lytic therapy? I mean, I would have at least considered it.
I think you can consider it, but I more thinking the distal embolic protection.
I mean, I think then the other aspect is, would you just primarily stent this now with the idea that you would trap whatever remaining debris or thrombus may be present and then aggressively balloon it rather than, I mean, I think that might be that would probably, in my lab, that's probably what I would do as the next step.
But I think you would definitely want to know the size, right? So take a look and then probably put a bigger stent than first meets the eye, because that distal segment looks pretty.
Right, that's a good point. Any other thoughts, comments?
I agree. I think lytic therapy would be an option, but I think it could also make sense in this case, potentially use an angiojet or jet stream with some aspiration components. I think now there's enough concomitant dissection that finishing the case and not, doing overnight lytics makes sense.
You know, people don't talk much about power pulse spray anymore, but, again, that would have been an option, so you could use that, where you're using mechanical thrombectomy along with a short course of lytic therapy all in a contained sort of thing, so you're not doing a long-term lytic drip. So, and we found it to be very effective, particularly where you have relatively unorganized thrombus.
Yeah, I think that's great for acute thrombus. I think the more subacute or chronic stuff, I think it's a little bit less satisfying, and I think there's some more embolic risk with the angiojet, with pulsing the fluid into the lesion. So I definitely would use distal protection for that. I mean, I think this is different with the vigorous aspiration aspect to this device.
Great to see this device in action. I think in the absence of our having it, I think Jetstream with embolic protection. And certainly at this point, I don't think I would lyse it with all the dissection. I think it's going to be headed towards stenting.
Yeah. Okay, yeah. Yeah, probably, we cannot take more out now with the Rotarex device. After 2-3 passes, that's actually what you can achieve. I'm not sure whether some other thrombectomy device like the angiojet would be more effective. Actually, I don't think so, because I think they rather work in more fresh thrombus, but this is clearly somewhat organized. At the end, probably we need some stents here. Question is now whether we predilate here everything. However, I would in fact do this here under filter protection, predilate, and then see how we will come along with how many stents, potentially drug-coated balloons, proximal rest stent. Yeah, what do you think? Good strategy, or?
I think at the moment, in my opinion, okay, this is a very good maneuver to bring the guide wire distal again. But then I would go ahead with a balloon, because to perform a lytic therapy at the moment can be dangerous, because and I suppose that the lytic therapy is not effective, and to use other debulking material system now could be also problematic. That to go ahead with the balloon, and personally, I wouldn't use any protection.
Yeah, I
No
mean, I think
protection?
the only other thing is what you suggest. took an IVUS catheter down there, you knew it was 7 or 8 millimeters, and then you just put the stents in so that you know you're trapping it, you know that you're going to get expansion, because you can back up and down and then aggressively dilate the stent. I think that's a safe and effective way to do it.
And the question is now which
Pazifik
stent?
520.
Because if you want to take a bone stent, then you have to prepare for that.
Nicht knicken.
Such a long lesion, a simple nitinol stent, in my opinion, a prescription for wrist stenosis.
The only thing, you can go straight in.
And then you have to use a drug-eluting stent, and you have to use 3 drug-eluting stents. And I would use a simple balloon for all the area, and then maybe a drug-eluting balloon.
Yeah, I mean, I think, you know, he has a very nice lumen at this point, or at least a reasonable lumen compared to what he had. So I think now it's a matter of, the other thing is we do have non-drug-eluting stents in the longer sizes. You could potentially treat this
Yeah,
with
exactly.
one long 200
Sagst
centimeter
du mal, wenn du ihn siehst.
non-drug-eluting stent.
Ja, ja.
So just, Andre, for just full disclosure, you have about 3.5 minutes left of time. So we don't mean to rush
Oh, yeah.
you, but
Maybe. Okay, okay. But maybe you have a presentation, we can show you the result, or?
Yeah.
Is this
okay,
possible?
all right. So shall we do that? All right.
Thank you. Okay, so we ballooned everything with a 520, and after that, in fact, well, as you can see, just a moment, sorry. Still, of course, residual stenosis and air bubble. Also, you can see 10 centimeter or 8 centimeters distal to the origin, quite some strong, yeah, probably old thrombus. So therefore, we decided here to take some stents in. We took silver PTX 642 two stents in. That's currently the result, which I think looks now very nice. Actually, I can also not see any cobblestone effect from thrombus here squeezing through the strut so far. Filter, potentially something here at the filter proximal part, but otherwise, I think quite nice.
It is
Yeah, again, I think this kind of mix of thrombus and, yeah.
it's very nice, Andre, but I just for us to learn why you didn't use in this situation now a drug-eluting balloon to prepare the vessel and then to use the interwoven stent, and you prefer to go a drug-eluting stent.
Yeah, we thought, I mean, there was not over the whole length thrombus remaining, but at some areas, spot areas, there was some old ugly thrombus attached to the lesion, to the arterial wall. We were afraid that this, I mean, first of all, I think just drug-coated balloon would not have worked like this. Potentially, yes, a combination out of drug-coated balloon, plus Supera may have been a good solution, but here, once again, that area here in the mid portion is difficult to treat without stents. Of course, I mean, taking in some Supera stents into thrombotic lesions is difficult because you have to predilate several times, and with every predilation, the risk of embolizing increases. So therefore, we actually don't use Supera stents in the more thrombotic or subacute occlusions or lesions.
Yeah, but this is a very
Okay,
good
but so far-
explanation.
Yeah.
Yeah, that looks very
Yeah.
nice.
Just treating that first portion with a DCB, and thereafter, hopefully, we are done. Maybe we have time to give here an angio here from that portion.
May I put it back on a little bit, and then we can go for post-ballooning stents.
Again, any comments from the panel?
Do you think it's necessary to thrombectomize above the filter where there was that filling defect?
Very good results, the proximal portion.
Yeah, that
I
looks
mean, the
very
filter,
nice.
There was maybe some material, but yeah.
Yeah. We are very happy with this now. Question is really whether we have to post-dilate the stents. We can actually also leave them as they are. With the aggressive pre-dilation with 5 millimeter, I think there's good enough opening here of that stent. Question is now how to take the stent out. Shall we take
The filter.
a guiding catheter to be able to aspirate maybe potentially some thrombus attached to the filter, or shall we take the regular retrieval catheter here? Just a moment. I'll do one more angio here.
No, not much. This is maybe a little dissection or flow.
It certainly doesn't
Yes,
look
I think
like
we
it's
just take it out
obstructive.
and then we're done.
Yeah, yeah.
No.
All right. So you have to let us know where there's any material in the filter.
Yeah.
We know it in a second.
Moment. Das war ein trockener Dingens.
Trocken? Halb trocken?
Try to take the delivery system, retrieval catheter out without squeezing the stent ends. Just a moment. Stop, stop.
You still on it?
Okay.
Okay.
Haben die schon? Do you have to talk now? Or?
There is something in.
Yeah.
It's not visible very well, but there is something in.
Okay. So far, okay. Okay. Not sure whether we are still live, but
Yes, yeah, you're still live. It looks
we're
very
quite
good.
happy
You
with
have
this. No
good flow.
embolization.
Okay.
Yeah,
Nothing that looks like
Yeah.
distal obstruction.
all fine. Yeah. Okay,
All right.
finished. Yeah.
Nicely done. It looks very good. Let's give Dr. Schmidt a round of applause.